So, hello, yes, it has felt a bit like the Leicestershire and Rutland takeover for this session, but it's great to see so much fab stuff coming in Leicester. I'm the head of strategic BI at Leicestershire and Rutland ICB, and Rob is our lead analyst for the Health and Equality Support Unit. Just to give you some context and background, I haven't been around for that long, and when I wrote the abstract for this conference, the Health and Equality Support Unit hadn't actually been established, so I was being a bit premature in the abstract submission. But if you can get us on to the next slide. So, when I wrote the abstract, the HISU, our Health and Equality Support Unit, was a bit of an idea. It's a virtual unit. We brought it together across the system, so it spans our acute trust, our 3 local authorities, the CSU. We've got some really good session-based clinical input into the unit, public health, academic links from our research board. We've got the CSU on board. We've got people from primary care, and we've got knowledge and library for evidence services in there as well. So we've done really, really well at kind of selling the unit, getting really good buy-in, getting all sorts of people involved. Well, next slide, sorry. And what we want the unit to be is we want to be the local experts on health and equalities data. We want to be setting the direction of travel around analytical methods. And we also want to be providing some of the expertise around the evidence base and where to go for the research evidence base. And it's all about improving the quality and evidence of the ICS for health and equalities. What we're not trying to do is replace the work that's going on around health and equalities anyway. Health and equalities is fundamental to all of the work that everybody's doing. What we want to do is provide some of that additional focus around some of the really big priority projects that we've got. So what I'm going to do now is hand over to Rob, who is our lead analyst and the only substantive member of the team. And he's going to talk you through the first bit of work that we've done, which is a deep dive into the work we've been doing around childhood immunisations. And I'll mute it.
Cheers. Cheers. Hello. Yeah, that's working. Just plug myself in. So this is a couple of clip. Hopefully everyone can hear me okay. I'll keep this quick because I know people are probably waiting for a coffee. So as Janine said, our first project, our first deep dive really was looking at childhood immunisation rates and inequalities in that across LLR. This is specifically for children 5 and under, though we will look at adolescents going forward as well, because that's obviously quite important. So we basically, this is a snapshot of where we are in LLR. The data is published by Cover, so a lot of you probably seen it already. And we've looked at the uptake rate in County and Rutland, so that's effectively Leicestershire and Rutland without the city. It's published as joint between County and Rutland, so you have to we have to show it as joint, though we can split it out by practice. And looking at the take rate in city and then LLR as a whole. So this is basically up to the end of last Q3 for 2022-23. You can probably see for yourself really a lot of green where the uptake is above 95% for Leicestershire and Rutland. So World Health Organization basically says it's got to be 95% or more for a population to be immunised, for it to be to work. City, you can see a lot under. So effectively, we've got the 3 age cohorts: 12 months, 24 months, 5 years of various vaccinations that are administered. As you can see, that the 5-year-old cohort, particularly within the city, a lot of them are struggling to get to just over 80%. If you look at MMR second dose, 77%. And so you can see that obviously there's some areas where we've got particularly low uptake in Leicester City, particularly, though there are pockets within Leicestershire as well which have low uptake rate. We know of an area in Market Harborough where they've got low rates because they've got a large traveller community and it's difficult to engage sometimes. So that's the state of the nation, as it were, in Leicestershire, Leicester and Rutland. What we wanted to do then was cross-reference that against the population of practices. So the data is published at a practice level, and then we wanted to cross-reference the practice data uptake to the practice demographics. Now, I think we've had a couple of talks already around practice level data, and there's a lot of it in Leicestershire. It's used in the ACG. But we do know that some of the data that comes out of it around ethnicity is quite fragmented and not always well recorded. I think we got it up to around 90 for GDPR, whatever we call it. But we do know there are some issues. Now, we've used the Master Patient Index, which is effectively the spine data, to sort of set the baseline for what the ethnicity and the deprivation are for each practice. What we have done here is do a bit of a comparison against what Census 2021 told us, and effectively you can see that we're not far off. None of these data sort of sources are perfect, but it gives us an idea of the characteristics of the practices we're looking at. So what we did there next is to look at the practice uptake, and it's quite a crude way of doing it, and we are going to move on to looking at patient level. We'll come on to that shortly. So we looked at the practice uptake by the percentage of the population of that practice that was an ethnic minority, Black, Asian or mixed, and that's on your left-hand side, and the percentage of the patient population that lived in a core 20 area on the right-hand side. So you've got deprivation across the bottom and then the ethnicity across the bottom. So what you'll see is these clump of practices here, and just stretch across here, practices generally with an uptake way over the 95%, and they tend to be practices with low percentage of Black, Asian, mixed population and low levels of deprivation. But there are some, again, exceptions. We've got practices here with quite high levels of ethnic minority population that are achieving 95%. But as a general rule, as these tables will show at the bottom, the higher the deprivation and the higher the percentage of the population from an ethnic minority, the lower the uptake. This is just a demonstration. So each one of these lines represents a practice. So we looked at the top 10 uptake. In the top 10 practices, the lowest uptake on the top bit, and then the top 10 practices with the highest uptake at the bottom bit. So obviously we just color coded it, so the greener better, and then the redder the lower uptake. As you can see, there's a clear correlation between the percentage of that population that's mixed, Asian, Black or other, and the percentage that is core 20. There are some exceptions here, this practice here, and this practice here, and this practice here. I've got relatively high uptake, or very high uptake, and relatively high practice with the ethnic minorities, their population. We then did some work, as Janine said. Some of this is not just around the data, it's also looking at best practice and the evidence, and what's been done in the system to help reduce inequality. And we spoke to various partner organisations and stakeholders. So we know that there's a screening and immunisation team run by NHS England. So we've worked with them, spoken to them, what they're doing. They've been involved with practices. They were at the workshop the other day that we had in LLR, looking at this. We've got the school nursing and health visiting team. So although they may not be directly involved in administrating vaccinations, they assist parents. We're looking at the Green Book and checking their child health records and encouraging parents and guardians to have their children vaccinated. We're working with Public Health Leicestershire. They are doing a detailed piece of work around this on health equity. And we've also got what we call the Super Vaccinator project in Leicestershire. Actually, it's more in Leicester City, where they're assisting practices with their vaccination programme and doing things like retaining COVID vaccinators and flu vaccinators outside normal sort of winter time, and targeting practices for low uptake. Almost done. So the last one is basically looking at the difference. We've talked around this between the practices with a high rate of ethnic minorities and deprivation in the lower rates. We've just to an arbitrary 30%. And then just to summarise, we've said about this as a clear relationship between high rate of deprivation and or higher level of ethnic minorities in the population. To crude methodology, we are going to look at practice patient level data from our CHIS services, looking specifically at the practices that haven't, the patients that haven't been vaccinated, patient level, to see if there's common characteristics with those patients, because it's quite crude just doing the two. And then we've talked about the data. It's quite fragmented. We're going to work with our partners in CHIS and LPT for a bit more of a sort of a more robust data exercise, so we can monitor this going forward rather than relying on covered data that's slightly out of date by the time we get it. And I think I've just done it in time.
Robert, Janine, any questions? Here we are.
Yeah, when we were designing the funding formula, one of the questions that came up was, should we introduce an adjustment for ethnicity? And we ummed and ahed about this. And so my question is, once you've stripped out deprivation and you've adjusted for communication issues and all the other things, is there an independent predictor of ethnicity for some of these factors, do you think? Or do you, because I noticed in your, you have some that are clear exceptions. And my hypothesis is it's a mixture of culture and deprivation. And once you, and it's not to do with ethnicity.
This is very Leicester City centric. Yeah. So the childhood vaccination uptake, we saw a presentation last week that suggested between 1 in 4 and 1 in 5 children in Leicester City are worried that they will be hungry today. When families are facing that kind of problem,
they don't get vaccinated.
The parent, it's not that the parents don't want to vaccinate them, they've got so many other things going on. So we're going to refocus this work to look at the unvaccinated. We're going to profile the unvaccinated kids to see what they are.
Really interesting.
You've got there are higher health needs. Diabetes is more prevalent in South Asian population, lower BMI.
Well, that's my question. Once you case mix adjust it, you strip out the diabetes.
Yeah, I know what you're saying, and I have been pulled out for using ethnicity and deprivation, but we do have inequalities and outcomes that are linked to ethnicity that are independent of deprivation. So we're at the start of trying to figure this out with the data that we can use, I think. Yeah, definitely. Yeah. I mean, there's the other thing is it's quite crude using Black, Asian, mixed, white, because we know that there's population within the white census population that's not necessarily split out in the NHS, thinking particularly Roma travellers, that sits under that A population, which we all use in the NHS data dictionary. But we know that some of those, once you split them out, are harder to reach communities. So it's really important, as Janine said, that we get the patient level stuff. The other things, cultural barriers to the interventions. So our next project's cancer, and particularly focused around inequalities in bowel cancer outcomes. And we know that there are cultural barriers to fit testing, so, and then to colonoscopies. So that will start, it's where in the pathway the inequalities happen and what are the barriers that we need to address to reduce the inequalities.
I was going to ask actually, at what point do you start talking to those population groups? Because there is so much hidden.
Job.
Oh, okay. Whose job is it?
That comes back. So with this, we've got quite a lot of it. The reason we picked immunisation is we've got quite a lot of projects going on, and we wanted to see if the totality of those projects was actually reducing health inequalities, and it's not.
So when do you start talking to those populations?
We are talking to, we've done a lot of talking to those populations, because it's the same populations that weren't having their COVID vaccinations. And yes, that's what the super vaccinated project's all about. It's how do we engage with populations that aren't engaging, but that's not our job.
Okay. Any more questions? One more question and then we'll break.
Yeah, I was wondering a bit more complex, so I need to follow up on the question. I know you didn't break it up, but I guess you must know how strong this correlation is. And how good is it at
that we
compares with other
our methodology at the moment is a bit flaky. So we are waiting to get the health equity audit data, which will be patient level data. So for every patient that we look at, we will know their deprivation and we will know their ethnicity, and at that point we will start to do the correlation work. But with the slightly iffy, so the methodology that we've been using with the work we've done so far isn't good enough to do. It's not, there's too much inferred, the numbers aren't robust enough. We need to do the next piece of work, which is the patient-level analysis, before we start to do that correlation work. So we're planning to do it. We can't do it with the data that we've got. It wouldn't be statistically robust.
What I will say is that whenever we've shown this to any partner organisations, LLR, and they've seen the practices, that everyone knows, including the GPs in those practices, they say, yes, we know we've got an issue. And so there is a correlation between the practices and those demographics, but it isn't a predictive tool at the moment. It's quite a crude, as Janine said, it's just quite a crude way of linking the two, because there are some exceptions, as you probably see.